Vic Gatto, and I have Dick Foster with me as well. Okay, so we are going to just get started. Again, Vic Gatto, I have Dick Foster here. We're going to talk through Jumpstart's 4 windows onto the post-COVID-19 world. I'm super excited to have Dick with me. Just before we dive into his background, just a couple logistical housekeeping things. This will be about an hour. We're going to keep it to 50 minutes to an hour and make sure we respect people's time. We are recording it, so if you have to drop off or something happens, we'll have it posted this weekend or sometime. And then if you have questions, we have a few questions prepared, but we'd like to answer things that the audience wants to hear about. So if you have questions, please use the QA tool in Zoom. You click on it and you can type in your question. Sydney will be sort of managing that, and then I will turn to that in probably 20 minutes or so, and we'll dive into whatever questions the audience has. So that's the rough plan. I'm really excited to have Dick here. He has been studying innovation and how markets change and disruption and how creative disruption affects businesses for years. And great to have him with us today. Dick, can you just give a little background of your work history and where you come out of this?
Yeah, thanks very much, Vic. So I started life more or less in McKinsey when we had 400 people at the time, and I left 30 years later when we had 16,000, and I ran the healthcare practice there and started the private equity practice. So I've done those things. Since then, I've continued in healthcare, and I'm on the board of Memorial Sloan Kettering and on a half a dozen different committees there. So I'm very much involved in healthcare and what's happening in the next phase of healthcare.
Yeah, excellent. And then I think a lot of people know me, but I'm the CEO of Jumpstart. We are a health-focused investment platform, investing in innovative health companies, really stage independent. So we invest very early, seed, meaning two or three founders trying to figure it out. We invest in venture and we invest in growth. So all along the private side of investment. And we really started probably 3 or 4 weeks ago trying to figure out what would the COVID-19 outbreak mean to our business, mean to our portfolio companies, mean to the overall economy. And Dick's been really helpful in sort of thinking through that. So thanks for joining, and we're going to dive right into it. And so the goals, Jumpstart, we set up goals for ourselves in this work, which were pretty straightforward. Three main goals. We wanted a simple framework, 3 or 4 options that ended up being 4 options, where we could understand just what are the guardrails. What is the worst case? What's the best case? How should we think about what this means to life, to the economy, to our business, to the companies we're invested in? It needed to be, secondly, detailed enough to be accurate and useful, but concise enough that we could make decisions and have discussions around it. And then the third was to really be a jumping off point for discussion. We don't think this is the answer that we hand down. We think it is more a framework to enable business leaders to have discussion about what this means to them, and then hopefully be more prepared. So that was the goals when we started it. We ended up with 4 windows into the post-COVID-19 world, named to sort of just be easy to reference: the scary speed bump, painful catalyst, push to the edge, and massive disruption with the government coming in to rescue. So those are the 4 scenarios. The methodology, there are pages written for statisticians and epidemiologists that we can dive into. When I say we, the actual experts, not me. But for this purposes, just in 30 seconds, how did we do it? Really 4 steps to it. We built a core model of the disease itself. How does it propagate? how does it grow? When does it peak? How does it decline? In any country, any population, what's the COVID-19 generic model is how we thought about it. It was based on the early knowledge out of Italy and Korea. I think the Chinese experience, they have a very different culture there. So we used Italy and Korea, but then we modified it to fit with, a generic model that wasn't specific to those countries that could be put anywhere. That was stage one. Stage two was to take that generic model and customize it to the US. The US has a different population density. We have a different culture. We have different adherence here. So that model is then overlaid to the US, and we're able to create different scenarios based on adherence, government action, how it would flow based on what actions were taken. And then we extended the model to consider the economic impact. So we went not only with the disease kind of trajectory and infected people, hospitalization, fatality rates, but what does that mean to society, to the economics, to businesses opening, to GDP, to employment numbers? That's what we really need as business people to be able to make decisions on. And so that was the full model. And then we believe in collaboration. So we brought in 41 collaborators. Dick was really helpful as one of the collaborators. The concept was that more minds, that the wisdom in the crowd, more diverse points of view would make it a better body of work. And so that's the general methodology for how we've approached it. Scenario one is called the scary speed bump. It is like the title makes it out to be. The total infections are 683. So these are very detailed predictions. We don't expect they're exactly right, but the model spits out exact numbers. The peak date has already passed. It's April 5th. All the cases are finished by the end of May, and general society returns to work and restaurants begin opening. People are back on May 11th. Unemployment peaks at 25%. GDP is negative, but just slightly. And so this is the graph. The green line is always going to be the case, the scenario projection, and the gray line is the actual cases today. And so you see, for a while, the speed bump looked pretty good, although we may be slipping a little bit higher than it's projected now. Scenario two, painful catalyst for change. This is like the next step where it is pretty painful, 3 million people infected, over 60,000 deaths, and it extends longer. The peak date has not been reached yet. It's in May. We have cases through August, and the return to work is not until the 4th of July. GDP is significantly negative for 2020. Again, hard to say. We could be much better than the painful catalyst. If this trends down now, we could be really good. It probably won't be as good as a speed bump. Not clear if we're going to get to that peak in early May of over 60,000 cases a day. These are cases per day. And then those are the two easier cases. Scenario 3 and 4 get much more dire. Luckily, I'm happy to report that 2 weeks ago, 3 weeks ago, when we were mapping this out, these were viable alternatives. 12 million people infected, 380,000 people die. Really a difficult scenario. Happy to report it doesn't look like, at least right now, it doesn't look like we're going to hit that, which is a great thing. I think important to have scenarios that include all the possible states that you could have, but we look pretty good to not hit this level of disease, which is great. And then the last one, massive disruption, 10% of our country infected, 34 million people, really difficult environment. there were days a couple weeks ago where I thought this was a really significant risk. It now looks like it is trending not that way. And so anything could happen, but part of the benefit of this is when we frame what could be, then we get to overlay the actual cases on it and feel like we have a better handle on the whole world. So that's the basic report. You can download the report at our website. I think I can send out the link later. I should have put the link on here. But the full report is 30 pages long. That's the sort of the cliff notes of it. Dick, do you have any comments on that before we dive into the prepared questions? I think you're on mute.
Number one, thanks for doing this. I think it's enormously useful framework. And as you've pointed out, when you went through the 4 scenarios, what you have built really is a set of tools that allows you to analyze any number of scenarios and even build new ones, which we'll talk about in a minute. But having that tool is really, really useful because it's the best tool I've seen, and you can play with the variables and see what's happening as the situation changes. So I'd just like to thank you on behalf of all the people that I'm aware of for doing this. I think it's super useful.
Great. Well, you know, I think I really appreciate that. You see a ton of stuff, so it's a great compliment that you think it's valuable. Honestly, we started just as selfishly for ourselves. I mean, Marcus and myself, the 2 co-founders, and then our management team, we were looking at the news reports coming in, and it's still coming in today, and it's hard to get your bearings almost of, right. Okay, what do we expect? What is the worst case? What would be a good case? We had no frame of reference. And so it started off for ourselves, and then we decided to open it up because I think all business leaders are going to need to figure out, you know, a lot of these questions for each of their own businesses. We happen to be an investment company, but it's true whatever business you're in, really.
No, that's for sure. So if I might, so let's go beyond what you've done so far. So how do you track as many of these different models as I do, many more? What's distinctive about the Jumpstart model in your view?
Yeah, I mean, I think that there are, I don't know, I've lost count. There are probably 50 to 100 models out there with scenarios and predictions. All the consulting firms, all the investment banks, lots of government agencies. I think we are trying to add to the conversation maybe in 2 ways. The first way is I don't think, unlike a consultant, like, I mean, your old firm McKinsey is doing it great. I mean, they do some of the best work. All of those firms really come out and their job is to be experts in their field, depending on what their take is. And so they are coming out with kind of the answer. We're not claiming to be experts. So I think one of the differences that we are trying to create a framework that can be a jumping off point or a beginning point for a management team, whether you're running a family-owned small business or a restaurant or an investment platform or a hospital. I think the decisions the management team have to think through are similar, and they have to understand kind of enough about the model to be able to make decisions, but have it concise enough that it's actionable. And so we try to present a model that you don't have to have an advanced degree in epidemiology to or be able to say it. In order to understand it, you don't have to really understand sort of how all the economic models fit together. This gives you a framework for saying what scenario are we in, and then what will we do with that. And then the second thing is it's holistic. So there's a lot of models out there that are around the disease only, which I think is important, but we felt like it was only the first half of the story. And so we connected this model of disease to what does that mean for employment and when restaurants can open and when I can go to the movies again. And I'm in Nashville. There's a lot of music industry folks here, and they make a lot of money by touring and having concerts and having events. And so, how do you predict when those events can be on again? If you only have the disease, then I feel like it's just not connected to how to make a business decision. So to me, those are the two things. It's more of a framework, and it's holistic in the sense that it's it includes the business side too, because we're business people that not epidemiologists.
Yeah, I'm certainly not aware of anything that is as broad as what you have. And is this available for others to manipulate and play with if they want to?
Yeah. It's available. We've had a little bit of a challenge in managing all the collaborators. So it sort of has grown. At first, I had maybe 6 to 8 collaborators, and then they brought in different people that they thought would be helpful. We're now at 41. And so we were on Google Docs, just sort of trading comments back and forth. And that has been useful, where this weekend we're going to sort of rethink that and probably come out with a different platform. But yes, I mean, people can download the paper, they can look at the existing Google Docs, but as it grows and more people want to chime in, I think we need a different and more scalable platform. So we're going to keep growing on that.
Perfect. It's a great contribution to everybody in this business.
So I want to get your perspective on this. You're on the board of Memorial Sloan Kettering, one of the oldest and strongest hospitals right in New York City there. Talk about it from the hospital perspective. How is Memorial managing this crisis? What is your perspective from right there in the city?
Yeah, so good question, and it's a daily question for all of us on the board. We started talking about this back in January. We started doing something and getting prepared. We put the first task force together in early February. It involved the reorganization of basically the whole staff, not taking them out of their existing day jobs. And as you know, if you're at Memorial and you have a day job, it's a 24/7 sort of job. But augmenting that with other responsibilities, and how would we continue to run the hospital while dealing with something like this? So we've worked out a solution for that. Everybody there is quite spectacular. I think there's an overall daily commander. We on the board get daily memos from them. We've cut back all surgeries that we can cut back to open up capacity for people. There are COVID positive people both on the staff and in the patient population. Fortunately, not too many at this point, and we're managing all of those. And then, we have 25,000 people that we're taking care of that have been through the hospital in the past and still have medical issues that have to be dealt with. So we're dealing with those people as well, and there's a whole infrastructure that's set up to answer their questions. So everybody is working very, very hard. I think it's quite impressive to see what they're doing, to see an organization that large turn that fast, that dramatically. So
yeah, so as I was going to point out, the ramp up has been dramatic. And for the most part, everything has gone pretty well. The capacity has held, I think. The capacity has held, and everyone is being treated. Of course, there are patients that have varying existing underlying conditions that make treatment, either more difficult or incredibly difficult. But I think the health systems, at least from the outside, you're on the inside, have really managed the process pretty well.
Yeah, I'm impressed with all my colleagues at Memorial. If you think about cancer, there's treatment of people who you know have cancer. They're in for radiation or surgery or something. And then there's people who are coming in to get early diagnosis, because the best way to cure cancer is to catch it in stage 1 or even before stage 0, some people call it. That work we've postponed in order to accommodate all of this. So the issue will come for us. There's a couple of issues. One, when this wave goes through, then we have a big backlog of these people who have been waiting for a while. We're going to have to figure out how to handle that, and I'm sure they'll do a magnificent job of that. The second,
let me just interrupt you. So, and unlike a knee surgery, which so every elective surgery has been sort of delayed around the country, but unlike a knee surgery or a true elective surgery, cancer treatment gets worse every day. I mean, so
right.
it is.
If
I'm sure it's nervous making for the patients to get delayed.
And of course, there's a huge group of patients that don't know whether they do or they don't. And some cancers, I mean, you can have prostate cancer and live for 25 years, right? You can have prostate cancer and more likely die of pneumonia than you are of cancer.
Yeah.
So there's that uncertainty that goes on as well. So they're managing all of that. But all the docs have redeployed from their normal daily routine to take care of this crisis.
Yeah. And then, Dick, talk about the testing ramp up, because I'm not sure it's at Memorial, but we were talking earlier, the testing, the growth in capacity has been really incredible.
Absolutely extraordinary, actually. And we see it increasing every day. At Columbia, I know that I just was listening to a report by one of the chief docs at Columbia a month ago, when they had a sample that they wanted to test. They'd draw that sample, they'd package it up, send it down to Washington, and then if they were lucky, they'd get an answer in 3 to 5 days about whether that sample was positive. Today, they're putting 1,000 samples a day through Columbia, on the way to 3,000 samples a day. And the report out time is in a small number of hours as opposed to 5 days. That's a total game changer. And that's just getting started. All that, there's a huge backlog of science that's yet to come there, but the progress that they've made is unprecedented. Some people will compare what's going on now to 1918. And I'm thrilled to say I don't remember 1918, but it sounds like it was not very pleasant to be around. And I don't think we're anything close to 1918. There's the science base that we have now, the hospital base that we have, the social support service that we have. That's it's not at all like 1918.
Yeah, I completely agree. I think the bug or the virus threat seems to be contagious like the Spanish flu,
right?
And threatening like that, and yet our health system infrastructure, and I'm the first one to sort of question health administrators and health systems in my previous life, because I think they could do better. But the health system in Israel has held up incredibly well, and the people inside the infrastructure have really done a great job rising to the challenge in pretty scary environments where they all have their own health to consider. They have met the challenge incredibly well. And then I think also the community, the culture, and the government reaction and our adherence to that has been very good. Where in 1918 we didn't have the infrastructure, the government didn't really tell us. I mean, I wasn't here either, but it didn't really inform the public that well. And then, of course, there wasn't great adherence, so it went past really long.
Yeah, we're in a totally different state now. That doesn't make us less vulnerable. It makes us differently vulnerable. And we also have our weaknesses. In 1918, people weren't flying in from Asia and Europe every day. Right. And that's where the disease seems to be coming from. We didn't have the population sizes. We certainly didn't have the science. So this is a do-over. This is not a do-over. This is a restart where everything has to be thought through very carefully. And if the thought is that this is going to be the last one of these, I'm not one that would support that point of view. I
Yeah.
think, I don't know how many COVID-19 viruses are out there, but it's got to be hundreds of trillions. And they're all trying to mutate in order to survive. And a few of them will. And that'll become COVID-20. And
Right.
then we'll see what happens with COVID-20. And maybe it'll
Yeah,
be
this- so
something,
this-
you know, we've had MERS and SARS, and now we've got
Right.
COVID. Maybe we'll have a new name for it. So,
Yeah, I mean, this class of respiratory viruses, broadly called coronaviruses, you just named MERS and SARS, COVID-19. We all are much more acutely aware of them now. They systematically come up every year, and there is just a variety of contagiousness and lethality in each one. But I think they also, I believe they mutate every couple of days, they're mutating. And so
sure, you're right.
it's very hard to predict where they'll go. So
I think the only thing that we can predict is that a COVID-free or virus-free environment going forward has got to be a low probability assumption.
right. Yeah, so that goes to topic number 3. I took the slides down just because I'd rather have us be more seen. But you and I have been talking a lot about a second wave. Just for people's information, if you haven't seen them, the scenarios don't consider a second wave. And I thought it might just make sense to have a discussion about that. I mean, I think, Dick, both you and I think there's a very high risk, a significant risk of a second wave. So with this wave will crest and ebb, and we will take a deep breath. We will have our health systems can get themselves reorganized and maybe sleep a little bit. But this fall or winter, there's very likely to be another wave.
Yep.
And so
I think we're going to have two things this fall. We're going to have another wave, and we're going to have an election.
right, yeah.
And I don't think they're going to be unrelated. So maybe they'll be unrelated, but I would find it not convenient to make that assumption. I think you have to assume that there's going to be some interaction between these things, and this becomes a very complex system where you not only have the complexities of the medical system, but you have the complexities of the comment on the medical system,
Right.
Which has an impact on the medical system.
Yeah, no question. So we made the decision for version 1 that we just published this morning to not put a second wave in it, really to keep true to that simple and yet effective for decision making goal. The belief that I still have, I think, is that business leaders in companies, big and small, I mean, there's some very large, I saw a thing that Boeing might lay off a ton of people. And, you know, there's a restaurant that I love in my neighborhood that closed yesterday. Big and small businesses are having to make really impactful decisions in the next days and weeks about what do they do? Do they lay off employees? Do they call the bank and delay debt payments? And when should they prepare to reopen? Are they going to be ready to reopen? When will the government turn it back on? And so we made a decision to try to keep this set of scenarios sort of simple with only one wave, and then let people digest that and understand the 4 possible things.
Yeah.
I do think we're already working on version 2. There's going to need to be more complexity and a second wave brought into the analysis. And if management teams want to jump into that, certainly we can have a discussion. But I think there's a lot to be said for kind of building this, not super slowly, but in steps along the way.
Well, I think one of the things I really liked about version 1 was that it was understandable. Here's the situation. It's reduced to its simplest elements. Here's 4 variations of these. These are the implications. And then you stepped way beyond what everybody else is doing by looking at the longer term. What does this mean for food? What does this mean for investment? What does this mean for our lives? Which is, I think, a great contribution. I haven't seen anything like that.
Yeah.
So now I think it is a logical time to go forward and start thinking of some of these complexities that are coming up, and particularly the fall and what's happening there. I'm sure you'll get lots of good comments from the people that are involved in this session today, and I'm sure you are welcoming those comments, because it's the richness of the community that will really create the robustness of the forecast that you're putting together.
Yeah, I mean, for instance, I had a person I had never met before who runs an anesthesiology practice in San Diego, was willing to share sort of what their level of operations and anesthesia cases is now, very, very low, and then how they're preparing to relaunch that. They're planning to, do double time, triple time procedures, because just like in cancer, everyone is sort of queuing up all these procedures. It really is, the crowd is smarter than any sort of small group of people. So
for sure,
collaboration from lots of sources will make it better.
It's especially true today. Let me mention a couple of other examples of things I'm involved in. One is an OBGYN. That business has fallen completely through the floor, because that was a physician-centric. You went and had an exam. Not anymore. Right. So if you're 4 months pregnant, what do you do now? It's a big issue. And there's lots of OBGYNs in the United States. So for that particular brand of medicine, this is a huge change, and they're going to have to figure out a totally new way of delivering care. And some of that may be through video, but you can't do all of it on video. That's for sure. Video is another aspect of this. Another company I'm involved in is the largest provider of patient appointments in the country. And that business, you can imagine what happened to that business in February and March. Nobody's making any patient appointments. But what happened was everybody wanted to see their doc on the screen. And the docs most docs aren't prepared. You can't take a course in video medicine at any medical school in the world, which is quite incredible, actually. And that itself should change. But now they're coming on telemedicine, and their telemedicine demand is increasing at 20% a day, and it's in the six figures right now, increasing 20% a day. So people are figuring this out. What that means for docs, if you said for the first 30 years of your career that you don't want to do it on video, you don't have a choice. You better do it on video, or you're not a doc anymore. So these are huge changes in the structure of healthcare delivery in the United States, and my guess is they're not going away.
Yeah, so that was the takeaway from this work, I think, is that no matter which scenario we end up being in, and I think the truth is no scenario is going to be perfect, right? It'll be a mix of a few different scenarios in the middle somewhere. But what's interesting is all the scenarios, the conclusion is healthcare is going to change dramatically. Our economy is going to be changed dramatically. Really, our life, I was calling it the new normal in the document. We're going to have a recovery period where people sort of get back to some semblance of reality. But then the steady state, the new normal, is not going to be exactly like it was at Christmas time before we knew what COVID-19 was. It's going to be different. You're gonna see your OBGYN in a different. You'll go in person sometimes, but you're over video sometimes. I think all of healthcare is going to need to shift. So I want you to talk through. I mean, you literally wrote the book on creative destruction. It's a nationwide bestseller called Creative Destruction: Its Impact on Businesses. And I want you to talk about the legacy costs. So if people haven't read the book, the reason that big companies can't navigate this sort of innovation and change is they have a thing called legacy costs. I have a question for you about, in times like this where the world seems to be changing quickly, do legacy costs get more costly? Is it multiplied? I think it probably would, but you wrote the book. So talk about that dynamic, maybe define it for people, and then what is it like today versus last year?
Yeah, so Legacy. So there's three things that every business has to do. They have to get started, they have to run themselves successfully, and then they have to get out of things. Everybody thinks getting started is hard, and indeed it is. Everybody thinks running things is hard, indeed it is. By the way, the first guy that I've found that talked intelligently about running things well is a guy named Fan Li. He's Chinese and he was born in 531 BC. So we've been at this for a while, and we know pretty well it's hard, but we know how to do it. And then there's getting rid of things, and nobody wants to talk about getting rid of things. And those legacy costs and the existence of those are the things that bring down great corporations. If you looked at who was on the S&P 500 15 years ago and look at it now, you might be surprised to see that only half of those companies are left. And that's 15 years ago. That's not 50 years ago. That's 15 years ago. In 1986, IBM was 200 times larger than Microsoft. It's not 200 times larger than Microsoft now.
Right.
And it's not because they couldn't invent things. It's because they couldn't get rid of things in order to allow them to bring to market the things that they had invented. Lou Gerstner came in the early 90s, and he threw out about 80% of the businesses of IBM and got it started. And that took it up until Lou left, and then it flattened off again, and now it's come down again.
Yeah.
So
Dick, I think about this, I think in analogy terms a lot of times. It's just the way my brain processes things. I think it's sort of like a garden. Like if you want to grow a new plant, but you have your garden packed with other things that are much bigger, they take all the light and nutrients and water, and even if the plant is really have high potential, it just gets suffocated.
Right. That's exactly what happened. That's what happens in a corporation. It does not happen in a society. So these plants, then they don't grow in your garden. They grow in your front lawn or your neighbor's garden or someplace else. And that's exactly what happens. And that's what's happening now. And that will continue to happen. And it will happen with increasing speed as we go through these discontinuous events like COVID-19.
Yeah. So that's right. COVID-19 and anything that is a dramatic change to society, to our economy, it amplifies the cost of these legacy issues.
Yes,
so
it does.
Incumbents, that OBGYN practice that has never done telemedicine has to quickly get rid of old things that are crowding out innovation, or they're going to lose out to some new OBGYN practice that is being created in this time and just sort of starts up knowing that.
That's exactly right. Sometimes those old things are old docs. And those docs are very skilled, and they have great hands, and they have great interpersonal relationships, but they also have to learn how to augment what they've done in the past with what they're doing now. And they should always, I think you should always have a sense of what's the least productive 10% of the things that I'm doing in my life. And then ask yourself, am I prepared to get rid of those things? And if the answer is no, you ought to use that as a point for reflection. And that's true with docs as well, I believe.
Yeah, I mean, docs are hard because there's so much changing in medicine. I mean, I can't remember the stats, but there's like 1,000 academic papers published every day that a doc would have to keep up with. No human could keep up with it.
Yeah.
And yet we haven't moved to the place where in other industries we are that, I don't know, an airline pilot or a stock trader or a business executive, we all use various tools to augment our human cognition. And docs have not been able to avail themselves easily of that. There's nothing designed for them, really.
I think that's true. I'll go back to this other point, which I think is quite important, which is, tell me the medical school which is teaching all of this to the new generation of docs. I don't believe there is one.
Right.
I know that there are some experiments that are going on, but the longest course you can take in some of these new areas like telemedicine is 3 or 4 days. Well, you don't have a surgery course that's 3 or 4 days, right?
Right.
And this is, so we're going to have to reconceptualize how we teach medicine, I believe, in the coming, and by the way, I don't think we have a long time to figure out how to do that. I think we got to start this now. I'd be very disappointed if next, not 9 months from now, but 20 months from now, we don't have a few medical schools in the country that have major investments in teaching those new docs how to use these new technologies, which are going to be here.
Yeah, I think they don't have a choice. So some school is gonna step up and do it, and then it's almost like a herd mentality. Then once someone does successfully, then every medical school will come on and try to do it.
I think that's exactly right.
Yeah. Okay, let's talk about our point of view given the companies we're involved with. So at Jumpstart, we have 86 portfolio companies. They're all in healthcare, all different stages of private company growth. You're involved in a bunch of companies. Let's just review quickly. I see pretty bifurcated marketplace. So in health innovation, there's about 30%, 30 to 40%. I don't think it's half, where they are seeing incredible demand lift. And so you were talking about ZocDoc or one of the appointment gathering firms. That's true in my portfolio too. We have a prescription delivery service, and it used to be a nice to have, convenient thing to have my script delivered to the home, but it wasn't a necessity.
Right.
And then overnight it's gone to I need it that way.
Right.
They're experiencing, multiples of growth daily, new records daily. There's probably, of the 86, roughly a third to 40% that are can't keep up with the demand. And that of course brings its own challenges. It's better than the alternative, but it's challenging, particularly in healthcare, because it's people's medications or their life or their video chat with their doctor. It's not like delivering a pizza where if it gets a little cold,
Right.
It's frustrating, but you're okay.
Right.
And then we have the other side that is the demand has evaporated. There's no need for their service anymore, and they have no revenue coming in at all. And so for those companies, we're trying to help them navigate this, weather the storm. There'll be a need for, their service is needed, just no one is doing the thing that they need that they do right now. It's an in-person healthcare interaction. What are you seeing out there in the companies that you follow?
Well, I think the ones I follow, but by the way, I think there's quite a lot of startup companies that are out there, or companies that even pre-startup, medical students or combinations of medical students and engineers and so forth, who have some very interesting ideas. But to get those into the system is very, very hard these days, and they don't have enough experience to really know how to do that. Navigating the provider space is very, very difficult, and providers are very busy providing, as it turns out. They're very busy doing exams. They're very busy doing surgeries. They're very busy doing follow-ups and all those kinds of things. And are they eager and out there looking for companies? By the way, all of them will say they are, and to some extent, all of them are, but no one that I know is looking comprehensively or thoroughly through all the alternatives to make the best decision. It just happens to be the ones that come through the door. So that's not the best possible way one can imagine doing this. Then there's this group called the payers that seem to have something to do with all this, and they say, not on your life. We just want it cheaper. And well, it's cheaper for what? And cheaper for how long? At a large hospital that I know well, we've done retrospective studies on lives after treatment at this particular hospital versus other hospitals. And according to this data, which is millions of patients over 20 years or so, yeah, the lifetimes are longer. So is that a good thing or a bad thing? Well, if you're a payer, it's not necessarily a good thing.
Right. Yeah. I mean, there's your perspective. If I'm the patient, it's a great thing. If I'm paying for the care, it may not, it may be the opposite of a great thing.
Yeah. So, and now if my employer is paying and wants to have the least cost for his health insurance, and he's paying for that, but that they're paying for how fast you get out of the hospital as opposed to how long you live, well, that's a totally different objective. So we're going to have to address that, I think. And so I think that's another aspect of this that has to be taken into account. So you have this little 2 to 3 person company. They're all 28 or 32 years old. They don't know anything about any of these things. You know, they're a spectacular physicist or a good geneticist or whatever, but they don't understand all of this. And I think that's really the need and the need for guys.
Yeah, so that's it's interesting you say that, because that's really that was the insight that Marcus and I had 5 years ago when we founded Jumpstart, is that we work with really the combination of the industry buyer, so could be a hospital, could be a payer, could be a physician group, could be a retailer or employer, whoever needs health innovation. We want to understand what are they demanding, what do they want help with, and then we work with really engineering heavy teams of 2, 3, 4. It could be 20 people, but they're mostly people building stuff, engineers, whether they're mechanical engineer, software engineer, maybe a biochemistry. They typically don't speak the same language. I mean, so they're speaking English, but we are doing English to English translation is how I think about it. And bringing those engineers to the buyers and helping them sort of customize that solution to fit with what's actually needed. There's a lot of disconnect between those two groups.
You know, I've worked with a lot of surgeons over time, and the people that work with surgeons, the radiologists who look at the various X-rays and MRIs and so forth. There is technology out there now which allows, with a normal MRI or X-ray, to see it at 10 or 20 times the detail level with the same image that you would before, and therefore mark lesions in a way that you couldn't have done before. No doc 2 months ago, if you'd ask him what are all the things you need, would be 20 times more accurate lesion measurements, because they don't know that that's a possible thing to get, right? And these people who are doing the lesion measurement, the accurate lesion measurement, don't know enough about the docs to know who to talk to and how to talk to them. That gap, that communications, that conceptual gap, is the thing that we have to work hard on fixing. I think the potential.
There's so much wasted effort in building engineered products that there's no market for, and there's so much need out in the world for great solutions. We just have to connect those dots together. So
yes, great solutions, and we don't even know what the problems are right now. So I think we need people who understand enough about medicine and enough about the technology to say, you know, if you could do this with that, it might. They don't know how to do the engineering, but they can see the potential, and I think that's an exciting area. And by the way, it's happening all the time. When you see a great medical innovation, you'll know that's what happened. When Fred Moll developed intuitive surgical, nobody was talking about automated surgery, right? And it's still not really automated, but it's kind of automated. But he had that vision. He was the one that conceptualized something that couldn't have been conceptualized before, and then brought it into place. And those are the people that I think those are the people you're investing in. Those are the people I'm most interested in. Being with.
So I want to get to some of these questions from the audience. So will we update these models and graphs with actual data and do this call again periodically? I think yes. We're updating, we're doing another version right now. We'll update the models and graphs daily, and then we'll publish it, you know, periodically. I don't know if it's weekly or bi-weekly or how we will publish it, but as quickly as is needed. The disease seems to be shifting very quickly, and so that requires lots of iteration and shifts. The next one, how much do you expect the COVID-19 to drive Jumpstart investment choices in May? So for the audience, Jumpstart invests in Jumpstart Foundry, our seed fund, does 15 to 20 investments in May, and then 5 to 10 investments in the fall. I think the world has changed. And so it feels like a new normal that we're headed towards, that everything's going to be different. So I think it would be crazy for me to say this won't influence the investment decisions in May. But I'll say that we made, a batch, maybe we did 18 investments in 19. We're going to do 15 to 20 investments this May. We're continuing our pace. We may even be increasing our pace. But the type of innovations that are needed, I think, might be different. Working through these scenarios and the conclusions, I've just learned a ton. And so I think that's going to inherently change the way we invest. Dick, what's your perspective of how you'd invest today versus a year ago?
Oh, there's almost no comparison. And I'm certainly I'm focused a lot more on the real disease. So I've had some investments in companies that are improving scheduling in ORs and things like that. Those are really good. But I'm much more focused now on the real disease side. What can we conceptualize? What can we do? What does this mean for? So certainly pulmonary disease. I mean, pulmonary disease has always been important, but it's never been viewed as one of the well, I guess that's not true. It might be the number 3 or number 4. Well, pretty soon it's going to be number 1, I think.
Right.
This will the understanding COVID and how it actually works in the lungs is going to have implications for how we look at the liver. It's going to have implications for how we look at the bowels. It's going to have how we look at the prostate. All those things are going to be affected by the innovations that we have here. So I think I think this will be a time for real science-based innovation to get even stronger in medicine than it has been.
Yeah, so that makes sense to me. It also feeds into one of the next questions, which is, how would you advise those creating new solutions, new strategies, deal with the issue of kind of regulatory or government risk, where with the stroke of a pen, state, local, federal agencies could change reimbursement or change what's allowed? And it particularly is true in therapeutics or disease treatments. How do you think about managing that risk in an environment where there's lots of government intervention?
Yeah, it's a great question. It's such a vast question. I'm involved on the funding side of small healthcare research efforts in academia, and I can tell you that the average age of a RO1 right now is 44 years old. That doesn't make any sense. It should be 34 years old or some number like that. So we're not looking, the government is, I understand what their need is because they have all this money they have to spend, but they need to look further down, some of the younger people who have the fresher ideas, I think. So we need a way to solve that within NIH. I think that would be one place. Yeah. I think the FDA is trying to move pretty hard to move faster than they have in the past. And I only applaud those efforts and hope that they do them even more. And the whole issue of how we pay for in healthcare in the United States, it's just going to be an enduring issue. Its roots are in political economic philosophy, and I don't think we're going to make up our minds about those very soon. I think it's going to take us a long time. In that context, I just hope that context doesn't slow us down in terms of getting to great solutions.
Right.
So I wish I had super direct, clear answers to your questions, but I don't. I think I think we're going to be wrestling with this for a long time.
Yeah. Okay, so let's talk about this one. What are the top 2 or 3 drivers that we should all be watching to assess kind of the near-term future for small healthcare companies, either in these scenarios or another thing like case counts, or maybe it's the date of the first elective surgery. That's a date that we plucked out in the scenarios. What do you think we should be watching for, Dick, out there?
Great people. It just, you know, I wish I had a better answer, but over time, there's some people that stick with it, that, you know, are working day and night, who have the ability to ask that precise question, who aren't just technical experts. They can reconceptualize the problem and put it in a different concept, and they're massively energetic. And so to me, that's overwhelmingly the most important thing.
Yeah.
I think the next thing is we still need more intermediary organizations to help these folks who are in medicine and who want to go beyond medicine understand what it is that they're trying to do. Many of them, I would say the majority of the early stage companies that I see, their first question is, how can I raise money? My answer is, you know, their money only comes from 2 places, investors and customers. And with customers, you don't have to give it back.
Right.
So why don't you focus on the customers more and really get to know them? And then they'll say, well, you know, a customer is the National Institutes of Cancer. No, that's not a customer. A customer has a telephone number, and you can call them up and you say, hello, Mary, and that's a customer, right? Yeah. Otherwise, it's not a customer. And most of these early stage ventures don't understand that at all. So I think we need to get to them. I think we need to give them some simple instructions about these are the kinds of things that you should be doing, and then introducing them to healthcare systems that are excited about the potential and understand the disruptive nature, disruptive to their own operations, and have, it's not just, can we bring in a new surgical tool? It's how are we going to change our surgical processes in order to use that tool? And are we willing to do that? I think we need to work on that side as well. So those would be.
Yeah, I mean, that's one of the things that I'll just pile onto with that. I think coming out of the scenarios that I took from it is, whatever scenario we end up with, it doesn't matter. The health systems are going to be in need of innovating their business model, innovating what they do with the community, figuring out a way to pivot from providing critical care, urgent care in this COVID crisis to a long-term viable business model. That's not at all clear. They have to make that transition. And I think innovation is going to be one of the main things that they use. On the payer side, they seem much stronger, that their revenues are not as affected. They're going to come out of this much stronger. And so where can they help? Where can they be collaborative? And can we prevent them from sort of doing things that sort of corrupt the independence of the health system? I think those are the challenges we need to answer as a society over time.
I think that's great. I think if people took that advice, we'd be far better off a year from now than we are now.
Yeah. Okay, and then the last one is how do organizations that have meaningful COVID-19 breakthroughs and solutions, how do they cut through the noise and get their answer to the right people to make decisions? I mean, that's the question. That's what Dick's talking about as far as you know, every hospital is looking for innovation. They're all finding it. Unfortunately, it's really noisy. There's a lot of not that great solutions, and it's hard to find the signal in all the noise. I don't know, Dick, do you have comments about that, what they should do?
Yeah, no, I think it's an absolutely great question. And I think it's a question we should focus on and follow up on quite a lot. And I think it does rest with the payers. Payers are large institutions, but you know what? There's only about 20 people in the payer organizations around the country. If we had 20 active payers who understand what it takes to bring new medical technology into their system, that would be an enormously productive organization. Now they talk about it themselves, but the broad conversations have to be held with increasing frequency and increasing intensity. I think we need to move this forward.
I mean, one of the things that I've been trying to think through, we're not going to have time for it right now, but we really need a standard process to assess, evaluate, measure, validate these innovations can make a difference system-wide, countrywide. And then when they do, let's adopt them much more broadly. Right now, you have to do it at each health system one at a time.
Right.
And everyone has a different pilot process and different way to measure things. And it's just very inefficient.
Absolutely true. Right. Yeah. Figuring out how to make progress on that would be absolutely great. And a consortia is, in cancer, you have the NCCNs, which is fine. So, but I'm not aware that the NCCN has a big effort focused on innovation per se. They've efforts focused on science, but not on innovation per se. Right. And what if you put Cleveland and Mayo and Denver and a variety of these other places together, Stanford, and said, okay, we're going to focus on this innovation. I think the payers are ready for that. I think other non-cancer providers are also ready. But and maybe we're better organized for that than I think we are, and I'd love to hear about it if that's the case. But I think we can advance on that as well.
Yeah. Good. Well, that's all the time we have. Thanks everyone for listening. Dick, thanks for your wisdom. It's been really fun to talk through. I wish it was in better circumstances, but we will. I mean, I have sort of inherent optimism that our country is strong, our people are great, and we will come through this. It's a trying time, but we'll come through it, and then we'll figure out how to innovate and bring new solutions to health for us.
Thanks, Vic, for all your incredible leadership and bringing these models and getting these dialogues started. Very important. Thank you very much.
Okay. Thank you, Dick. Thanks everyone for listening. Appreciate it.